Good morning, everybody. All right, so thanks for coming over and for having me here. So these are two, very different topics, and they're quite broad, but I'm going to try to summarize them all into, one lecture. And if you have any questions throughout the lecture, just feel free to ask. If not, we can, have questions at the end. So the topic today, we're going to start off with acute kidney injury, which was previously called acute renal failure. And we're going to first discuss, the current definitions. We're going to see how those definitions apply across different populations. We'll talk a little bit about the epidemiology of AKI, the etiology, what causes it, then supportive treatments, and then some of the emerging therapies, or what's new or what's coming down the pipeline. Okay, so let's get started. So first of all, how do we define it? So AKI is the abrupt onset of renal dysfunction. So the key thing here is abrupt, right? Leading to inability to regulate the acid and electrolyte balance and excrete wastes and fluids. And usually what happens is we have a decrease in the GFR, or the glomerular filtration rate, and that's characterized in our labs by an increase in the creatinine, and in the patient clinically by a decrease in their urine output. So that's typically what we're going to see. And like with any medical problem, there's typically a spectrum of AKI. And the biggest hurdle that we've had over the years is that there are over 30 definitions in the published literature. And most of them are one-dimensional. There's really no staging. And we don't really do this for probably any other thing, like, New York heart disease classification, for cancer staging. They're not really all one-dimensional, but for acute kidney injury, it is. So that poses a problem. And the prior definitions, they were all, specific changes in creatinine or changes in creatinine clearance, things of that nature. And the reason it is important is because understanding acute kidney injury and outcomes matters. So adult data have demonstrated that even small changes in creatinine is associated with mortality. And AKI is associated with mortality and increased length of hospitalization for our patients. So we know that acute kidney injury is a recognized factor for poor outcome, independent of the severity of illness for that patient. So we have to be quite vigilant about it. So this is a study by Cherto and colleagues of adult patients that were admitted to the Brigham and Women's Hospital. And what they found was that a small rise in creatinine of 0.3 milligrams per deciliter, independent of severity of illness, heart disease, diabetes, and so forth, conferred a 4 times odds ratio or risk of death, and a increase in creatinine of 0.5 milligrams per deciliter increase your likelihood of death by 6 times. So that's pretty significant, right? And as your serum creatinine increased, your risk of death increased as well. So we need a classification system for acute kidney injury that is multidimensional, that is able to grade acute kidney injury in severity, that allows us to follow changes in kidney function, and that is also standardized for hard outcome measures, so that when we look at, let's say, papers that are published in the literature, when you guys read about something in textbooks, that the definition of kidney injury, renal failure, or whatnot, from one textbook to another is the same. And then we can compare we can compare, one intervention to another and so forth. So this is what's called the AKI rifle classification, which has been proposed now for a little bit over 10 years by the Acute Dialysis Quality Initiative. And it does just that. So it stratifies patients in what's called risk, injury, failure, and of course then loss and end stage. But what we're interested for the purposes of AKI is the RI and the F, and it's based on GFR criteria, so changes in creatinine or GFR and urine output. So risk would be, of course, milder, I more severe, failure, of course, the most severe. And this is an adult classification, and it's been utilized, and it does exactly what we need it to do. So it's a multidimensional classification for acute kidney injury. Now, the rifle classification has been utilized and subjected to, to study of over 500,000 patients. And when it's been associated to mortality, what we've noticed is that as you go up on the rifle strata, for any study that's been evaluated, mortality increases. Now, the rifle classification has been modified to a pediatric classification called P-rifle, or pediatric rifle. And it uses an estimated creatinine clearance that's determined by what's called the Schwartz formula, which is a formula that we use to calculate GFR in children. And it uses a baseline creatinine clearance calculation for those where data is not available. And it differs a little bit from the adult rifle in the oliguria definition, or this urine output definition, and especially in the failure limit, where we're using a body surface area calculation as opposed to just standard changes in serum creatinine. And when the P-rifle has been subjected to systematic review, and with the addition of about 11 other studies, a total of about 10,000 patients have actually been evaluated using P-rifle. And all these patients have had, of course, AKI to some degree due to different types of conditions. And what we found is that, P-rifle AKI rates and distributions are varied by the populations, that have been studied, but that most of the studies showed that there was an association between P-rifle I and P-rifle F with mortality or length of stay. So similar to the adult study as well. So the greater the degree of renal injury, the greater the likelihood of mortality, and the longer that you stayed in the hospital. So outcomes, again, associated with P-rifle I or F. So I guess what this tells us is that we should be really vigilant about who is probably in that P-rifle R, right? The initial stages of acute kidney injury. And maybe our intervention should be to those that are very early on in the course of the disease, so that we can maybe alter the outcome. So I guess standardized AKI definitions show that these small changes in creatinine are independently associated with poor outcomes. The severity strata demonstrates that worsening AKI severity increases the rate of poor outcomes. And that is critical because you guys are there by the patient, and we need to understand that renal failure is just not one thing, right? Oh, this patient has renal failure. No, renal failure is a spectrum of a problem, and it affects, again, mortality for the patient, and it affects how long they stay in the hospital. Now, what causes acute kidney injury? Well, this was a study that looked at actually 2 different decades. You see here from 79 to 88 and then from 89 to 98. And what it showed is that the causes of AKI are shifting a little bit over time. So primary renal diseases like HUS actually decreased from 25% roughly to about 15% from the first decade to the second decade. Sepsis remained an important cause of AKI, and hematology-oncology complications increased from the first to the second decade. And what we do know is that AKI due to secondary causes seems to be more important than primary renal disease. And that is true even now for developing countries, where before primary renal disease seemed to be maybe more more important in those countries. And when you look at the top hits in the literature, secondary causes like sepsis, ATN and hypovolemia, nephrotoxic medications are always of utmost importance. And then hematology-oncology patients and patients after cardiac surgery, they're always the ones that we have to be the most vigilant for, because they're at greatest risk of developing acute kidney injury. So think of these things. If your patient is coming in with sepsis, if they're very dehydrated. Here we have a program that's called NINJA that is a surveillance program that looks at whether the patients are at risk of nephrotoxicity due to the the medications that they're on. But then of course, if your patient's a hematology-oncology patient, based depending on medications that they're on, or somebody's coming out of heart surgery, they're at greater risk. And a lot of these patients, if they have multi-organ dysfunction, if they're in the ICU, of course that places them at risk of AKI. So what's the incidence of AKI? So if we look at the PICU, where we actually had probably most of the studies have actually looked at this, and we actually know that our denominator, it depends on, I guess, where in the world you are. So if we looked at studies here in the US, in the ICU, roughly about 10% of patients will develop acute kidney injury. If we look at other studies, these are studies coming out of Turkey where fewer patients were evaluated, but roughly about 40% of patients developed AKI. And if we look at how many patients developed acute kidney injury and needed dialysis, it also varies quite a bit, anywhere from 1 to 6%. Again, you can see this here in the US is anywhere from 1 to 3%, but in other places it can be higher. And in patients after cardiac surgery, remember those are ones that we deemed high risk, right? Well, the literature varies quite a bit, from anywhere from 0 to 31%. So anywhere from a third of patients, I guess it depends on what type of procedure they're having, etc., can develop AKI that would require dialysis. Now, one thing that is very important is to understand that acute kidney injury happens early. So when we look at this study, and we look at what's called the P-rifle max, so the highest strata in the classification of AKI that patients developed in the course of the hospitalization, you can see that occurred on day 1, 2, or 3, right? So most of these patients, the renal failure happens early. So it's not something that's going to happen later on, or I guess it could, but the majority of the time it happens very early. So again, the patient is coming in, you're assessing the patient at intake, you're taking a history and all that, and you have to be assessing some of these things to try to gauge whether or not some of these patients are going to be at risk for acute kidney injury. Because again, P rifle max, acute kidney injury is going to happen early. So what actually happens in acute kidney injury? So this is kind of, it's a little bit of a mess, right? So you have this ischemic injury that leads to severe ATP depletion that causes this cascade of events that eventually leads to cytoskeletal degradation and apoptosis, that in the presence of, you know, a lot of oxidant molecule release, that in the presence of labile iron leads to oxidant injury. So you have here the insult has occurred, there's severe cytokine release and inflammatory response, the cells are dying, there's sloughing off of a lot of the tubular cells or epithelial cells, but there can be, you know, differentiation and proliferation of the cells that are still viable with eventual recovery. So if we look at the natural history of AKI, you have, you know, this pre-renal, you know, section here, then followed by the actual event or injury with the initiation of AKI, then an extension phase, then a maintenance phase, and then a recovery phase. And then you have the different time points in which you can intervene, right? If you intervene here, maybe you can prevent AKI. If you intervene here, you can limit the extension phase. Here, you're treating an established AKI patient, and so forth. So what actually goes wrong with the patient? Well, like we talked before, you have a decrease in GFR. Typically, there's oliguria, so that's going to lead to volume overload. And that volume overload is going to translate into pulmonary edema with respiratory failure or hypoxia, tissue edema with, you know, just increased weight. So if you're monitoring the patient's weight, you're going to see an increase in weight over time, or congestive heart failure. The patient may develop hypertension just from intravascular volume excess as well. So you're going to be noticing increased weight, respiratory compromise, and then high blood pressure. And then you're going to see in the labs metabolic changes, particularly hyperkalemia, metabolic acidosis, hypocalcemia, hyperphosphatemia, and typically hyponatremia, which is dilutional. And what you're going to see is, of course, uremia. As there's decreased GFR, there's going to be uremia, and then uremic symptoms with disorientation and so forth. So let's talk a little bit about management of these patients. So most of the time, we have what's called conservative management. And that's what we typically begin with, right? In conservative management, we usually think of things as diuretics. So, well, we said that the patient has intravascular volume excess, oliguria, volume overload, right? So it makes sense to use some sort of diuretic that would increase urine output, improve fluid balance, and hopefully even permit the delivery of fluid that the patient actually needs, like nutrition, antibiotics. And some of the diuretics increase potassium loss in the urine. So if you use a loop diuretic like furosemide, it may help augment potassium loss. So if the patient is hyperkalemic, that would be helpful. So we know from studies, either randomized or non-randomized studies, that most patients actually receive a diuretic. So most patients that have acute kidney injury receive a diuretic. But diuretics are not really effective in improving survival or renal recovery. So that's a surprise, right? I mean, well, they do help in some of these things we talked about, like, you know, increasing urine output, increasing potassium excretion, and so forth. But in terms of improving patient survival or improving the recovery of the acute kidney injury, they're not really effective. So they may aid in the overall management, but they're not really going to change how quickly that kidney recovers. So that's just something to keep in mind. So we've attempted many things to try to improve the acute kidney injury and outcome. Diuretics, osmotic diuretics like mannitol, low-dose dopamine, right, that's supposed to increase renal perfusion at low doses, glucocorticoids to decrease that intense inflammatory response or cytokine response, atrial natriuretic peptide as a natriuretic, and acetylcysteine, right, which is kind of a scavenger. And none of these have actually been proven to be effective in changing the outcome. So what we end up doing most of the time for these patients is trying to improve perfusion. Usually, if the patient is hypotensive, either by giving fluids or, if they're dehydrated, of course, we hydrate, giving fluids either orally or IV. If the patient is already fluid overloaded, then we limit, of course, the intake of fluids. We usually put them on some sort of restriction in their diet. If the patient is hyperkalemic, hyperphosphatemic, we want to restrict those substances in the diet. We use, again, some sort of loop diuretic to try to augment losses of potassium, for instance. And very critical is to try to avoid any further nephrotoxicity. So, if the patient is on gentamicin, we want to get rid of the gentamicin. If the patient is on, let's say, ibuprofen or Toradol for pain, maybe we find an alternative for that medication. If the patient is going to go for a CT scan with contrast, we want to try to avoid the contrast, if at all possible, for that patient. And then we, of course, try not to mess up, and we just wait for the recovery. Now, if all that fails, then we do what's called dialysis. And this is something that was actually thought about in the 1940s. And this was the first dialysis machine, which had this rotating drum, and the dialysate would go in this barrel down here. And the way that it would work is that blood was taken from the patient, and it would go around this sausage casing and then back to the patient, and this drum would rotate, and dialysate would be down here, and then that would, of course, cause the osmotic exchange with the blood and the dialysate. And this was about 20 meters of sausage casing, which you needed about 2 liters to prime the entire system, which is a huge amount. I mean, you can imagine if you're an adult's blood volume is 5 liters. It's about half of an adult's blood volume. So the first 16 patients, of course, didn't make it. This was one of the first patients that underwent early dialysis. You can see here, this is the patient's cannulated. This is the drum over here, which is rotating. And the goals of dialysis is, of course, to restore fluid and electrolyte and metabolic balance. You're trying to remove these endogenous or, at times, exogenous toxins. And if you're removing fluids, then you're hopefully allowing for needed therapy and nutrition. And you're trying to do this by limiting complications of the therapy. So we have several options. We have hemodialysis, peritoneal dialysis, or what's called continuous renal replacement therapy. And each, of course, has its advantages or disadvantages. And typically we choose the modality based on how sick the patient is, how hemodynamically stable the patient is, and what the goal of the therapy is. If it's just fluid removal, if we're trying to correct electrolytes, are we trying to do both things? And then also how comfortable the physician in the center is at doing certain things. Like some places they may be more comfortable doing only peritoneal dialysis. Some places may be really comfortable, let's say, doing CRT in the ICU, and so forth. So a lot of that depends on, as well, on the comfort and the expertise of the center. So hemodialysis uses a extracorporeal circuit. So you have this machine that mixes a dialysate or fluid that eventually is going to be going counter current to the patient's blood. So you have blood that's taken out of the patient by this roller pump, and it goes through a hemodialyzer, and then you have this dialysate that goes counter current to the blood, and then there's a semi-permeable membranes that are in the filter, and they allow for the exchange of potassium, bicarbonate, calcium, and so forth. And then you can create a negative pressure in the filter and cause a ultrafiltrate, which is this. So you're removing water from the patient. But it does require vascular access. It may require anticoagulation at times. And if the patient is very sick, they may not tolerate it very well because it's a very high efficiency system. But it's very effective, and it's very effective. This is peritoneal dialysis. And here you have to use a peritoneal dialysis catheter that you introduce in the peritoneal space, and you use sterile dialysate, and that goes through the catheter into the peritoneal space. It's allowed to dwell, or you leave it there for a certain period of time. An exchange happens between the capillaries that are there in the peritoneal cavity and the fluid, and then you drain the fluid. And it is better tolerated. It is a lower efficiency system, but there's always a little bit more risk of leaking around the catheter or infection, such as peritonitis. And then this is the ICU modality, which is called CRT, or continuous renal replacement therapy, which is very similar to hemodialysis. Again, it uses an extracorporeal circuit, but this is a slow and continuous therapy. So it's a lower efficiency, but it's better tolerated, especially for critically ill patients. So this therapy will, once you connect it to the patient, rather than doing it for, 3 or 4 hours like hemodialysis, it'll be there 24/7, let's say, or until you decide to disconnect it from the patient. And here you have the dialysate bags, and a similar thing would happen where there's an exchange here at the hemofilter or hemodialyzer, and then you create an effluent. So which modality is best? So to be honest, when this was actually studied in adults, looking at, let's say, CRT versus intermittent hemodialysis, you can see that there's actually no difference, right? So there was no difference in survival whether people use an intermittent therapy versus a continuous therapy. So it really depends on which modality the center is expert on, choosing the right modality for the patient. So it doesn't matter whether they go on peritoneal dialysis or CRT, which is maybe fancier or whatever. The main thing is that you achieve what you're supposed to achieve with dialysis. And if you do that, there won't be any difference. It doesn't matter what modality you choose. In pediatrics, this was looking at actual registry data. So this was just, retrospective review of the literature. And there was actually a poor or, lower survival in patients that were on hemofiltration or CRRT. But I think what happened here is that there's a bias, right? So these patients were much sicker, and this is what leads to the lower survival. So this is registry retrospective data, so it's not, best quality data. So again, just this is a little table from the KDIGO guidelines, or the Kidney Disease Improving Outcomes guidelines, and this just kind of summarizes a little bit what we discussed. So if you have somebody that's at high risk of developing AKI or in the initial stages of AKI, what you want to do is, number one, look at their medications. Try to discontinue anything that's nephrotoxic. Make sure that they're adequately perfused, that their volume status is appropriate. Make sure that they're adequately monitored, right? Make sure that you're checking labs, measuring urine outputs. Ins and outs are critical for us. Daily weights usually for these patients is also important. In these patients, hyperglycemia is also detrimental to the tubules, renal tubules, and we want to avoid that. And again, if somebody's going to go for a CT scan or a contrast study, some sort of angiogram procedure, you want to make sure you question that, or at least say, hold on a moment, is this really needed at this time with this patient's increasing creatinine? Is there an alternative to that procedure? As you go further along the AKI stages, then you consider whether we need some sort of invasive diagnostic workup, whether we have to start to change the dosing of medications because now the patient has impaired kidney function and some medications have to be adjusted, and whether we have to start thinking about something like dialysis. So this is kind of like a little bit of summary of what we discussed. Now, these are some of the emerging therapies. So do you guys remember this slide from before, right? The ischemia, ATP depletion, and so forth. So these are therapies that are undergoing research, either in animal studies or the initial phases of human studies. So if you have this massive ischemia, then you can use theoretically a vasodilator like phenoldipan to try to mitigate that initial ischemic event. Again, you need labile iron to be able to, progress to that oxidant injury. So using iron chelators like deferiprone is also under study to try to prevent oxidant injury. Inhibiting apoptosis with what's called a small interfering RNA is also under study. And then in patients, looking at an anti-inflammatory response like alpha MSH analog, or in the repair portion of it, like stem cells, is also something that's being looked at. These are all things that are probably, hopefully, going to come out if they are found, or at least one of them, to be successful in maybe the next 5 years or so. So you may see one of these therapies in the future. So in summary, for acute kidney injury, it's a recognized factor for poor outcome, independent of the severity of illness. It is important for us to identify these patients so that we can implement some sort of strategy to prevent further injury. And we can safely treat complications of renal failure with multiple modalities. But we do have certain limitations about what we can do. But there are some future strategies coming up, and hopefully we can implement more targeted therapies to these patients. Okay. So then we'll move to chronic kidney disease. Any questions on acute kidney injury? Okay. So this is CKD now, and we'll briefly touch on some of these topics as well: the etiology, pathogenesis, how it's classified, the clinical manifestations, lab findings, a little bit on imaging and treatment. So CKD, the etiology of it really depends on the age of the child, right? So if you have a very young child, you start thinking of things like congenital anomalies of the urinary tract, like renal dysplasia or hypoplasia, obstructive uropathy, like posterior urethral valves in males, something called prune belly syndrome. You think of genetic disorders like polycystic kidney disease, or acquired disorders like cortical necrosis if there was a difficult delivery, renal vein thrombosis, infants of diabetic mothers, for instance. If the child is over the age of 5, then you typically think of some sort of acquired disorder with nephrotic syndrome, like focal segmental glomerulosclerosis being probably the number one. But there are other things like lupus, hemolytic uremic syndrome, that are also causes of chronic kidney disease. And there are certain inherited disorders that present later in life, like Alport syndrome, nephronophthisis, which is a disorder of tubules, polycystic kidney disease, which of course the adult form or autosomal dominant form presents later in life, or something called cystinosis, which is a disorder of the transport of cysteine. So when you look at NAPRTEX data, so this is registry data for children about what the causes for dialysis for these patients. So here we have 7,000 patients on dialysis. The primary diagnosis, as you can see here, is FSGS, which is a form of nephrotic syndrome. And then you have congenital disorders of the kidney, obstructive uropathy, reflux nephropathy, so recurrent infections with reflux, lupus, right? So these are the main ones by far. And then you start seeing like 3%, 2%. So these are much lower numbers. So these are the big ones here. So in CKD, you have this progressive injury due to some sort of structural, metabolic, or genetic disease, right? So you have renal dysplasia or obstructive uropathy or something like that. That leads to hyperfiltration. So the remaining nephrons are now compensating, they're working harder. That leads to an increased hydrostatic pressure in the nephron, and that causes further injury. So those harder working nephrons are going to start to let's say overwork and burn out. So then there's further loss of nephrons due to this hyperfiltration injury. Most of these patients, because of their structural damage or the hyperfiltration injury, will have proteinuria. And proteinuria itself is toxic to the tubular cells. So now you have you have this initial injury, whatever it was, that's causing hyperfiltration, which is leading to more injury, that's causing proteinuria, which is leading to further injury. And now you have, of course, chronic kidney disease on top of that, which leads to, for instance, hyperphosphatemia or some mineral disorder. And hyperphosphatemia leads to calcium phosphate deposition in the renal interstitium, which is also, of course, damaging to the kidney. So you have all these things kind of working against you that all started with this initial injury. So CKD is classified based on this KDOQI guideline classification. And it's really dependent on your GFR. So it's classified from CKD 1 to 5, where 1 is you have normal or increased GFR. For instance, if you have a diabetic with microalbuminuria, but they have normal GFR, then they would have CKD stage 1. Or if you have a sickle cell disease patient with microalbuminuria, they may actually have an increased GFR. That's also CKD stage 1. And then as your GFR starts to decrease from 60 to 89, 30 to 59, 15 to 29, you go down or you go up on CKD stages. And then CKD stage 5 is when your GFR is less than 15 and you're typically in need of dialysis. So what typically happens to the patient? Well, it really depends on the underlying cause for their renal disease. But if, when we look at neonates, if they have some sort of congenital renal disease, number one, sometimes you know that beforehand, so before they're born. So there's some sort of prenatal ultrasound that notices there's something wrong either there is hydronephrosis prenatally, there is, oligohydramnios during the pregnancy, or something like that, and then you get consulted, sometimes even prenatally. Or the baby is born with what's called Potter's sequence or syndrome, right? So the baby there's oligohydramnios, and then there's that sequence associated to the severe oligohydramnios. Or failure to thrive, the baby isn't growing well, isn't thriving, or babies have polyuria or recurrent urinary tract infections. If you have a child or adolescent, these are typically, we said, these are usually nephrotic syndromes like FSGS, lupus, something like that. Then you would see changes associated to that, such as edema, hypertension. You may see hematuria, either gross hematuria, or you may be able to pick up microhematuria or proteinuria on a urinalysis. And if somebody that has long-standing CKD, that we sometimes see somebody, just shows up and they've had CKD for years that's been undiagnosed, they may have pallor from having anemia of CKD. They're usually short, and they may have rickets or bony abnormalities as a result of renal osteodystrophy. So typically in the labs, what we see is, of course, an elevated BUN and creatinine. Children with renal failure usually are hyperkalemic. We see a metabolic acidosis, right? Hypocalcemia and hyperphosphatemia, and they can be hyponatremic as well. If somebody has nephrotic syndrome, we will usually see in their labs low serum albumin. Patients with CKD also, they have a low retic anemia, and the anemia is usually normochromic, normocytic, and that's because of a decrease in erythropoietin. So the kidney makes erythropoietin. So if you have low erythropoietin, you have a low reticulocyte count, so you're not producing as many red cells. Urinalysis, you're going to see typically hematuria or proteinuria if there's a glomerular disease, or in patients that have tubular disorder, then they can concentrate the urine, so the specific gravity is going to be low. And nephrotic patients, they usually have high cholesterol and triglycerides. Most patients, we end up getting an ultrasound, and that's usually quite valuable in helping identify what's happening and helping us with the differential diagnosis. Sometimes other studies like CT scans or MRIs may be indicated, but the starting out test is an ultrasound. And if you see something like, shrunken kidneys, then you know that this may be either chronic or intrinsic renal disease or, renal hypoplasia. If the kidneys are normal sized and echogenic, it may point out to something like an acute glomerulonephritis or acute tubular necrosis. If it's completely normal, it may be a pre-renal situation or acute renal artery occlusion. If the kidneys are enlarged, then you think of something like, malignant infiltration or renal vein thrombosis. Or if you see, of course, hydronephrosis, then you think of obstructive uropathy. So this is just a ultrasound image where this is a kidney, and this is the collecting system of the kidney, and you can see that there's dilatation or hydronephrosis, which may indicate that there is some sort of obstruction. And this was a male, and if there was bilateral hydronephrosis, and the ultrasound tech looked at the bladder, and the bladder looked thickened, the bladder wall was thickened as well, then you would think that there was some sort of bladder outlet obstruction. So a small child with thickened bladder, hydronephrosis bilaterally, especially if it's a male, you think of something, bladder outlet obstruction, posterior urethral valves. This is another ultrasound image. These are kidneys, and these kidneys look very echogenic. So these are just very echogenic kidneys. So, you think of medical renal disease, some sort of either, glomerulonephritis, nephrotic syndrome, or something like that. So the treatment overall is, you have to focus on many different things. Number one is the nutrition of the child. Some of these children require a lot of calories, a lot of volume. If they're small, they may not be feeding well. They may need an NG tube. They may need a gastrostomy tube. And most of these small infants, they need to be on special formula. Formulas that have low potassium, low phosphorus, such as Similac 60/40 or something like that. We sometimes do need the advice of a nutritionist, especially as they're growing. They may need supplementation, extra protein or, extra fat or extra carbohydrates to make sure that they're actually growing well. Especially those children that have renal dysplasia. They may lose a lot of electrolytes and water, and sometimes you have to supplement those, like supplement, salt or sodium chloride. Remember, a lot of these patients have to be restricted in terms of potassium. Sometimes we have to give them an exchange resin like a Yexolate if they're hyperkalemic. Patients are generally acidotic. Children that are acidotic, they don't grow well. It causes further bone disease. So we typically want to treat that with either sodium citrate or sodium bicarbonate to maintain a bicarbonate level that's typically close to or normal. And we want to look at bone disease and calcium, phosphorus, and vitamin D. So usually in renal osteodystrophy, there's decreased production of active vitamin D, decreased absorption of calcium with hypocalcemia, and then secondary hyperparathyroidism. So we usually have to restrict them in phosphorus, give them some sort of phosphorus binder like calcium base binders or something like that, and give them vitamin D therapy. Most of patients that have chronic kidney disease are hypertensive, either due to volume overload or due to renin that's produced by the injured kidney. So a lot of the times we use either diuretics or ACE inhibitors to treat the hypertension. If the patient has already very advanced CKD, we sometimes avoid the use of ACE inhibitors and we choose a calcium channel blocker or beta blocker. Immunizations are very important, especially if somebody is heading towards transplantation, right? So you want to make sure they are up to date with their vaccinations, especially all live virus vaccines have to be given prior to transplant. And always remember that if somebody has chronic kidney disease, that drug doses for certain medications usually have to be adjusted. So making sure that if somebody comes in and you pick up that they have some sort of renal disease, that we make sure that medications that we're going to provide to them, that we're dosing the right way for their degree of renal dysfunction. So these kiddos, they don't grow well. They're, most of the time they have growth retardation, and that's usually because of their metabolic acidosis, their nutritional deficiencies, their anemia, their osteodystrophy, and there's usually abnormalities in the growth hormone axis. So typically, even by correcting acidosis, correcting anemia, correcting nutrition, they still don't grow at the rate that they should be growing. Even if dialysis is initiated, sometimes growth failure persists. So in those situations, we provide growth hormone for patients. And in those cases, catch-up growth is usually successful. We do want to make sure that they do see an eye doctor and they get hip x-rays before they start treatment. And once they reach CKD stage 5, or if we're unable to reverse whatever was the cause of the chronic kidney disease, right, they do progress, Then we prepare for dialysis if that's the case, or if they're not able to receive what's called a preemptive kidney transplant or a transplant before dialysis. And the dialysis therapy that we choose is either going to be hemodialysis or peritoneal dialysis. And chronic hemodialysis is generally avoided in infants and young children just because of vascular access problems. You know, they need either a catheter or a fistula, and that's going to be problematic long term. Peritoneal dialysis is preferred because they can have a more normal life. You know, like they do their dialysis at home, they do it at night while they sleep, they can go to school during the day. But it does require parents to be involved. You know, they have to have a steady kind of home life and so forth. Sometimes we cannot do PD. If somebody has had, you know, many previous abdominal surgical procedures, it may be challenging. Or if they have something like a VP shunt, it's a problem as well. But the majority of the time, we prefer for chronic management of dialysis, we prefer peritoneal dialysis for children. Okay. So, any questions? I'd be happy to take.
What do you think the most important thing from your aspect is, as a physician, what would you want your new nurses to really focus on with children with chronic?
Yeah. Well, I think well, number one, I think for the hospital, for the acute patient, acute kidney injury, for instance, is number one, just being vigilant. Sometimes, you know, we tend to kind of brush off this, well, it's just, you know, a little bit of kidney dysfunction, it doesn't matter, or the creatinine just went up a little bit, it doesn't matter. It does matter. I think as we saw from the literature, you know, even small changes in creatinine have huge impacts in survival. So I think that's probably the number one message. So just being vigilant about that. Then number two, is for our patients that have, you know, acute kidney injury, then there's a whole host of things that are very helpful. Number one is we want to be on top of their vital signs, blood pressures, you know, things like that. We want to be on top of their urine output, ins and outs. We want to be on top of their weight, right? Daily weights. And then there are certain things that sometimes get forgotten, like, you know, does the diet have to be modified? Should there be fluid restriction or no restriction? Should there be, you know, dietary restriction or no dietary restriction? What about their medications? Does there have to be adjustment or no adjustment? So I think number one is being vigilant, and then number two, if something like this is happening, really making sure that we're following some of these things. What's the urine output? What's the weight doing? What's the blood pressure doing? Should we be intervening in some other way? And then questioning some of these things, like, you know, if you notice the patient, okay, creatinine is going up and the patient is on Toradol for pain, then asking the primary physician or whatever, should this patient remain on these nephrotoxic drugs? Should we find an alternative? Or somebody's ordered now a CT of the abdomen with contrast or something, and you've noticed that the creatinine was up, then you can actually, you know, you should question that. Okay, is there an alternative? Do we actually need the contrast? I've noticed that the creatinine is up. Because it really requires a team effort. I mean, everybody being, you know, just vigilant about these things and being on board, and that's really what makes the whole thing work, right? For the chronic kidney disease patients, is when the patient comes in, you are all going to be the first ones to, you know, interact with the patient. Then, you know, getting the history and knowing that this is what's happening, you know, before, because the nephrologist or whoever, you know, is going to come in later. So, by the time that the patient comes in, by the time that somebody else sees the patient, maybe a consult gets placed, the day later, a day after. So just getting a good history, knowing what's happening, that's going to be important, because those initial orders about what to do with the patient will depend a lot on the history that you've obtained. And getting the history that, yes, this patient has a renal disorder, what type of renal disorder and all that is going to help you decide how you need to treat this patient and manage the patient while they're in your care. You have to be, again, more vigilant about certain things, again, in their diet, their medications, their fluid intake, their blood pressure, and so forth. So I think those things are important. Number one, history taking when the patient comes in, and then just understanding that a lot of these patients are, have to be on different diets, different restrictions, medications. Sometimes there's a adjustment that has to happen, or certain medications that they just probably shouldn't be on. I think that's probably the biggest take home, I would say.